For a variety of reasons, which we'll unravel a little bit later this morning, mental disorders have become a big and a major problem in South Africa. Now, while some of these are short-term problems, such as post-traumatic stress disorder, exacerbated to a large extent by a violent society that is South Africa, there's a worrying and increasing number of patients who end up with chronic mental disorders, some of whom have to be kept in hospital for long periods, decades even. And you can only imagine what impact this is going to have on their aspirations, their careers, relationships, and their families. Good morning, and a very warm welcome to Bonitas House Call here on SABC2. Babanda kamjokana kandaba. Zulomnyama ndlela simhlophe. Bantu abakaphalo, bana umankhawulise ngemuthwana. Kerekatiba hotabu hayaka. I'm Dr Victor Ramathesele. Lena lo utsetsa ngaka ka tlu. Le tlangwana ha Saturday se sene metsotso ya le mashomararo re freletso hora ya borobedi hoseng. And don't forget to join our discussion by calling us on 011-326-4740 with your questions and comments on chronic mental disorders. Or you can send your SMSs to Bonitas at 33723. As we welcome to the studio, Bitumela Sefulo, who's the clinical psychologist at Butshilo Hospital in Soshanguve, as well as Dr. Matebe Madikho, who's a psychiatrist and clinical head at Tara Hospital. Completing the trio is Dr. Lerato Dikobe, who is a psychiatrist at Acacia Netcare Hospital, all of whom come from Tshwane Hospital. Or is it Tshwane Mamelodi? That's Pretoria, yeah? Beautiful. Colleagues, we're going to delve into a very, very critical issue here, talking about chronic mental disorders. Mzakaba ukota masikhwele esikaleni ke sihlabele mgama ke ntina singachwapha sicela intambo kamahova kanti kukho abantu angazinganzulu ngalomba esithetha ngawo namhlanje. Ake sijonge nansi inxeba ezasithela ngesigulo zengqondo. Khawuleza.
Schizophrenia, depression, dementia, bipolar disorder. These are all types of mental disorders which are defined as behavioural patterns which cause a poor ability to function under normal living circumstances. In other words, you struggle to cope. Symptoms vary depending on the particular disorder, but may include feeling sad, excessive fears, extreme mood changes, detachment from reality, paranoia or hallucinations, alcohol or drug abuse, sex drive changes, excessive anger, hostility or violence, and suicidal thinking. And it is a big problem. Globally, around 450 million people suffer from mental problems. That's 10 times the South African population. Certain factors might increase your risk of developing mental health problems. Stressful situations like a loved one's death, chronic medical conditions like cancer, brain damage as a result of a serious injury, traumatic experiences such as military combat, illegal drug use, and being abused or neglected as a child.
Very, very interesting. Dr. Dikobe, let's talk about, mainly and broadly speaking, and maybe for the sake of clarity and simplicity, we should just maybe say the psychiatric disorders, major groups are your neurosis and your psychosis. And as I simplified, I said neurosis are people who build castles in the air, psychosis are people who live in those castles. But having said of all of that, all of us have one form of psychiatric disorder in various forms. For as long as it does not interfere with our social and occupational function, it is not a problem. It only starts becoming a problem if it begins to interfere with the way we relate to people immediate to us, and if we cannot be gainfully employed as a result, then it becomes a problem. Now, at what point do you refer to a mental disorder as chronic?
You know, but by definition, mental disorders, it's an impairment of a person's thinking, emotions, or behavior.
Okay.
Now,
thinking, emotions, behavior.
And behavior.
An impairment of that.
And it impairs their
is a
social
mental
and
disorder.
Occupational functioning.
Yes.
Therefore, by definition, it's a mental disorder.
I see.
That impairment can be short-lived, a few hours, a few days, a few weeks. When we look at our diagnostic criteria that we use, for us to say a condition is chronic, the symptoms must have been present for 6 months or longer.
I see.
Then by
Uninterrupted.
definition,
Yes.
we say it's chronic.
Okay.
Yes.
I see.
You see.
So it's for 6 months or longer, Uninterrupted.
uninterrupted.
Satisfying all of those conditions that you've played.
Precisely.
Yeah, behavior, thinking.
Yes.
And also it interferes with the social and occupational function.
But on the other side, you find some patients are able to present, say, 2 weeks into those symptom disturbance, and we are able then to control and curb the chronicity or the long run of the condition to 6 months. We are able to treat, say, the first episode.
Okay.
When they relapse, it can be a year or 2 years later. Then we can still say this is a chronic condition.
Now, typically, Dr. Madikho, a psychiatric patient presenting like that, it could be any of the examples that we'll discuss a little bit later. Typically, when they are being managed, how exactly are they being managed?
The management of mental disorders typically has to be multidisciplinary and has to be holistic.
It means it involves more than just one professional.
Yes.
That's why you can say it is multidisciplinary.
Yes, yes.
And by holistic, what do you mean?
By holistic, I mean that in most practice and in most protocols and guidelines, treatment of mental disorders needs to follow a biopsychosocial approach.
Mm-hmm. Tell us.
Now, the first aspect...
Biopsychosocial approach.
Correct.
So it has to do with biological factors, it must also do with psychological factors, and it must also deal with the social environment that individual finds themselves in or that they have to return to.
That's correct. Now, the biological aspects of care, what it means, the first thing you've got to do is actually have to do a proper and thorough medical evaluation of the problem. So you would do medical investigations and tests. It would include blood tests, x-rays, because there are times when you actually find a physical cause for the psychiatric illness.
I see.
And if you identify that, then you treat it specifically, whether it's an infection, it could be a brain tumor, it could be a
nutritional disorder.
Exactly. Heart disease, liver disease, thyroid hormones. All of those things need to be properly assessed, investigated, and then they would be specifically treated according to the cause that is identified. Beyond that, a lot of psychiatric disorders actually have specific medication that can be used to treat them, whether you talk about depression, psychosis, mania.
Because they are as a result of certain chemicals in the body being not balanced in one form or another.
It could be that the condition is as a result of some chemical imbalance, as we commonly say. On the other hand, in some cases, it's not clearly, you cannot clearly say it's caused by chemical imbalance, but you could perhaps say there is an associated chemical
But
imbalance.
you know that if you introduce certain chemicals in the body, it will improve, you know, the way people think or the way they behave or their mood.
Absolutely.
Okay.
Absolutely, yes. So this is what is called, psychiatric medication, what is called psychopharmacology. So there are various psychiatric medications that have actually been shown to be safe and effective in treating quite a variety of mental disorders.
So that deals with the bio part.
That's the biological aspect.
I see. And then?
Then there are psychosocial interventions. And so that's where we talk about psychotherapy, and there are various forms and various...
Hold it. I answer. Now, this is your area. Now, he's already described that you see a patient, the patient has got a psychiatric condition. Dr. Dikobe has already explained exactly what it is, that what gets interfered with, the thinking, the mood, and the behavior and all of that, and then social and occupational function is interfered with. You make a diagnosis. He says in the treatment, you look at biopsychosocial factors. He's given us a sense that you first look for an identifiable cause, whether there's a disease in the body that is responsible for that type of behavior. Having done that, you then give substances, treatment, medications that are going to deal with that. Now comes you to deal with the psychosocial aspects of this condition. I guess all of these are happening concurrently, not one after the other. Now, what does this mean, psychosocial management of the patient?
This is when the patient will come to me and say, I've been to the doctor and they say I have this problem, and they tell me the diagnosis. And then I make my own investigations to ask, what is the problem? How are you feeling? What have you been doing? What has been happening in your environment, and so forth.
But in the ideal world, he will refer the patient to you, having given you all the history and everything else. So you'll find you still have to take your own history because you deal with a different part of that condition, as it were.
And also, as a psychologist, you ask questions differently.
Yes.
Because the typically medical practitioners look for the cause. I leave it to be open-ended so that the patient can say anything that comes up, and then I do my own evaluations and deal with whatever they come up with.
Okay.
So in that evaluation, I'm looking at interpersonal relationships, I'm looking at their symptoms, the behaviors, the feelings, I'm looking at how this impacts the environment, the people in their lives, and so forth. And that's when and I look at the stressor. What is the precipitating stressor for this?
The psychosocial
Yes.
stressor, as it were, that we
Yes.
said. They're usually, in psychiatric conditions, they're usually predisposing factors that make you vulnerable to a certain condition. But more often than not, there are specific events that lead up to the psychiatric illness. So you investigate both of those to find out exactly what is happening. What are the aims of your intervention as a clinical psychologist?
The aim is to treat or alleviate, depending on the level of functioning of the person and the level of impairment and so forth. The aim is also to mobilize social support, because it's important to look at someone who has mental illness in the context of relationships. If you go home to a wife who is depressed and does not want to get out of bed, and they're sad and they're crying, it frustrates you as a partner. So you look at how the family or the people in that person's life are affected by that and mobilize support. So that would mean psychoeducation to the family through family therapy, and it would also mean educating the patient himself or herself about the illness that they have.
Okay. Now, hopefully, having done all of this would be a patient with a brief active psychosis, or it could be post-traumatic stress disorder, whatever. After all of these things that you guys do, the patient will get better and will not have this problem again, unless, of course, they have another psychosocial stress or whatever. But they'll possibly continue with Bitumelo here just to make sure that they remain, strong and not vulnerable to whatever that is caused. Now, there are things that go wrong, I suppose, in what this is being done, that leads to that patient not going to full recovery, as it were. And that's when the patient then becomes chronic mental disorder. Am I correct?
Yes. And in that case, in terms of treatment, we then need to go into what we call maintenance therapy,
I see.
where we will treat the acute presentation, and then when we see that this person is not quite remitting, we continue with maintenance. And maintenance can go on for as long as 12 months, 24 months.
Yes. Yo, bana beso, a re ke ra khutsa he go hopotsa kotsi ya tshebediso e bohlaswa ya tahi le thethefatsi maphelong a rona. Bona fela ha o ya ka ntle ka bona batjha bana bokamoso ba bona bo le lerotho ka baka la mafu a kelello a tliswang ke ntho tsena tse re buang ka tsona ka tsena dithethefatsi. Ba be ka beng ba ntshetsa moruo wa naha ena ya bo rona pele mpa jalo ba dutse ba bona ba tjwatla dipetlele kwana ka talente tse kana tse modimo ba fileng tsona. Nna ke a tshaba taba. We'll continue our discussion on chronic mental disorders hang re khutla papatsong. Ha re matheola. Mogaiso ga wa latlhega le seng o gorogile ka tlhamalalo mo thulagagong ya gago ya mmamorato e bong Bonitas House Call e thupileng sefoka sa multilingualism mo ngwageng e hulereng ga gorogela o golagana le rona ka tlhamalalo mo nomorong ya 0113264740 kgotsa mafaratlhatlha SMS simolola ka mafoko Bonitas then 33723. Gompieno re menne diphatla re di bile thankgate bang le malwetse a tlhaloganyo a masisi e bile a sa alafe go senene chronic mental disorders ka Seesimane. Let's see a typical example.
I've got a mental condition. It's called bipolar mood disorder. And I take medication every day. And I was diagnosed in 2005. At the moment, I'm currently doing a vocational skills training here at Talisman Foundation. And it's working all right for me at the moment. My bipolar is type 1, where I'm manic, where I get to the extreme of when I'm excited, I get too overexcited. And then I become manic, and I have racing thoughts, and I just feel like there's a lot of things I can do at one time where my body can't take that. That's, in my opinion, that's what bipolar is. Yeah. It's been a rough ride, I must admit. It's been a rough ride, but I'm here now. I'm healthy. I'm taking my treatment. I think the best thing for me was to accept that I had a mental condition. I was diagnosed in 2005. I was 22 then, and it was scary because I don't know what was happening with my body and my mind. I was in a space where I was hearing things and seeing things, and it was very difficult because I ended up, my family took me to sangomas and witch doctors and all that. They tried to help me, but they couldn't figure out what was the problem. So I ended up going to hospital, which was at Baragwanath, and there I was treated, and I was given the diagnosis of being bipolar. The stigma behind it was very difficult, especially the first year or two from my family and my friends and at work as well. You know, I was seen as a person who was not being able to handle his liquor, or a person who was always, you know, different from society. Because I did end up in the streets for a while, and I was shunned upon as a person who's sick and doesn't need help or can't be helped, that type of thing. And at work as well, didn't understand what was wrong, because I kept going in and out of hospitals, and I didn't know what was wrong with myself as well, and I didn't accept it. So I thought it was the drugs and the alcohol, which it wasn't. With support from, you know, the support groups from SADC and people from Talisman Foundation, and at hospitals where we attend OT, you know, they gave me more insight into the bipolar mood disorder, and from there I was able to educate other people as well and to let them know.
A very positive story around a condition that is usually notoriously very, very difficult to manage. Would you regard bipolar as, to all intents and purposes, a chronic mental disorder, or do you get people who get diagnosed with bipolar, get treatment, and they're in remission, you know, for the better part of their lives?
Bipolar disorder is actually one of our chronic mental disorders. And also it falls under...
That is, you never really get healed from it. You never really recover fully from it. So
yes.
You keep it under remission. You have to use medication, you have to use many other things to ensure that you don't have a flare-up of it. Is that the other?
Yes, you do, although I will qualify it. But I think just to highlight that bipolar disorder is also classified in the category of conditions that are known as severe mental disorders. And I think from the patient that has just shared his experiences, you can see that it is something that has quite a significant impact on your life. And he made reference to bipolar type 1, which is kind of, you know, has severe manic episodes, and they may also experience depressive episodes as well during the course of the illness.
What do you mean by he referred to this manic, and you are referring to it again. Can you just explain exactly what a manic episode is?
So,
typical in bipolar.
So mania, or a manic episode, is a condition in which the patient's mood becomes higher than normal for a sustained period of time. It can be at least a week, or it can be shorter if a person is hospitalized before the end of the week, 7 days of sustained symptoms. High mood, or it can also consist of a very irritable mood where a person is kind of excessively angry without reason. And other features of mania you'll find that the person actually has increased level of energy, they become very talkative, they may actually have feelings that they actually have superpowers, so to speak, and they may have reduced a need for sleep. And if the mania is quite severe, they may actually also experience psychotic symptoms, that hearing things or seeing things or saying things that aren't real and so on. So the psychotic symptoms actually become part of the mania when it is severe.
I see.
Yes, that is what mania is about.
So this kind of patient will only remain in remission and normal and functional like this for as long as they are taking their treatment. If they stop their treatment, whether it is medication or it is psychotherapy, if they stop, there's a likelihood that they will relapse.
Yes. So what bipolar disorder is the kind of condition where a person will have multiple episodes of the illness, just in terms of its natural course.
I see.
So a person may have, to have the diagnosis, you have to have at least one manic episode.
I see.
Now, in addition to that, a manic episode, even without treatment, can actually resolve. So person actually can recover from it and return to a normal state of mind and normal function, even without treatment. The problem, of course, is that without treatment, one can really go through a lot of suffering for themselves and even for other people for weeks, even for months, in the throes of this illness. But once they settle, they can actually return to normal, go back to school, go back to work. The problem is, however, that there is a likelihood that within months or even years, there will be a relapse where a person experiences another manic episode, or they may also experience
How do you prevent the relapse?
A depressive episode.
How do you prevent that?
Continuous medication,
I have
maintenance
to be on
therapy.
continuous medication
Yes.
to maintain.
Maintenance.
Now, he said something very interesting, that he was in the streets at some point. What do you understand by that?
He probably left home, ran away from home, alienated himself from his family and his support system. Perhaps the family at that time believed the doctor's diagnosis, but he was still in denial. And maybe he felt it's better if I'm in the streets, because at least in the streets I don't have pressure to be taking medication.
Are these the people that you find roaming the freeways, some of them staying by the roadside, dirty, unkempt?
A lot of them, there's psychosis.
I
yes,
see.
Yes.
Because
Perhaps
they've lost touch with
schizophrenia.
reality.
Yes. Perhaps more schizophrenia. In terms of functioning, patients with bipolar disorder tend to function or return to normal functioning better than patients with schizophrenia do.
Okay. Are they dangerous? Are they a danger to society during the manic states or depressive states?
The conditions can be potentially dangerous because, remember, these patients are suffering from loss of touch with reality.
So they can do a lot of wrong things. In
Yes.
the
If
process.
you are hearing voices or you have delusions telling you that Dr. Ramathesele is after you, he's jealous of you, and here he is, he's coming after you, you will want to defend yourself, and that's when the aggression will
Because
manifest.
hallucinations is false perceptions, delusions is false thoughts or
beliefs.
false beliefs
Yes.
around. Now, he mentioned something very, very interesting, that at the beginning of his condition, the family moved him from one faith healer to another, from one sangoma to another. And possibly, as the statistics will indicate in South Africa, that pretty much about 80% of patients, at least of African descent, will consult a traditional or some form of healer other than the allopathic or the Western type of medicine. To what extent does this, influence the outcome of a psychiatric condition?
I see this a lot even with my own patients, that they would consult traditional healers. Traditional healers are often the first point of contact when the family does not know what to do. And then, typically they say, and because people want answers and they want to understand what's happening. And when you go there, often traditional healers give answers, whether
the answers are correct or not is
correct or
immaterial.
not.
Now, do you collaborate with them? Because I would suspect that the manner in which you approach the condition are totally different. Yeah.
In Pretoria, when I was still working for the state, there were attempts by mental health care practitioners, and they were doing marvelous work to try and reach out to traditional healers, and I was so their approach was so humble. They were saying, our patients consult them before they come to us, or sometimes they come to us first, and when they struggle to cope or to become better, then they go to traditional healers and say the doctors did not help me. So the approach was to educate traditional healers about mental illnesses, and so that traditional healers can identify and see that there's a bigger problem, and to motivate their own clients. I don't know if they call them clients, but to motivate their clients, our patients, to continue seeking medical help, or, even though they are receiving.
They don't say
treatments
it's
from-
either or, so they find a way of collaboration. Okay.
If,
You wanted to finish off?
yeah,
Yes.
if I may say, the thing is sometimes because of people's beliefs and cultures and so forth, if you remove them abruptly, then you may lose them. So that's why the collaboration is very important.
Because it's important that we should not deny people their
Yes,
beliefs, because if you do that, you are going to alienate them. You are not going to get their confidence, because
Listen.
cooperation, adherence is based also on a good relationship between the patient and the doctor. Just before we go to the ad break, now at what point do these kind of patients end up in a psychiatric hospital somewhere in Vescopis or Fort Napier, if it is in KZN, or Sterkfontein, where they are kept for years and years and years because they have lost touch with reality and they cannot really function in a normal environment? At what point did you decide that?
With the new Mental Health Care Act of 2002, it was made different to how it was in the beginning, where a family member could just go to the court and apply for a patient to be committed. It's no longer that way.
Okay.
A patient who is difficult to manage at home, they are violent, they are threatening the family, family feels unsafe, they feel threatened, they are then able to call the police, South African Police Services, to assist with removing that affected person, taking them to the nearest state hospital, where then they will do a 72-hour observation. And during that 72-hour observation, they will then be seen by a psychiatrist every 24 hours, and the report will then be written. And then after the 72 hours, it will then be decided if the person is responding to the medication and can then be discharged and treated as an outpatient, or if the patient is still not going to be manageable at home, they're still posing a danger to themselves or to society, they will then be referred as involuntary patients to those institutions like Vescopies.
Involuntary, like they are forced now, because both for their sake and for society or family's sake.
Yes.
Oh, very interesting. We'll continue our discussion on chronic mental disorders when we return. Welcome back. You're watching Bonitas House Corner here on SABC2 as we continue to tackle the challenges of managing chronic mental disorders in South Africa, the land of sunshine, the land van Sonskate. Now, that particular patient is a bipolar, and we don't have time to go into the ins and outs of bipolar disorder. Suffice to say, it's a psychiatric condition that can fit the definitions that we put today of what a chronic mental disorder is. And in fact, we said it's also classified as a severe mental disorder. Schizophrenia, how different is schizophrenia to bipolar?
Right, so schizophrenia is another severe mental disorder. The difference between the two is that whereas bipolar disorder is primarily an illness affecting the mood, schizophrenia is primarily an illness that affects your thinking and perception.
So it's worse, schizophrenia, in terms of occupational and social functioning?
Yes, so schizophrenia generally is worse in terms of the impact that it has on your ability to function. I think Dr. Dikobe did mention that earlier. So the level of impairment that one gets from schizophrenia is typically more severe than what you get from bipolar disorder. Although, having said that, there are some differences from patient to patient. You know, just as you would know with a lot of medical conditions, some people may be less affected than others. So generally speaking, schizophrenia has a worse impact on your function than bipolar disorder. So now, going back to schizophrenia, it affects primarily your thinking and your perception. And the key features of schizophrenia are as follows. Firstly, is that your thoughts may be disorganized. Just the way in which you're able to think can be impaired, where you're not able to hold your train of thought. So during conversation, for example, you may start off talking about one thing and end up talking about something totally unrelated.
What you guys call loosening of associations.
That is an example, yes.
Yeah.
And another feature is the delusions that you actually referred to earlier, where you start holding to incorrect and false beliefs. You may believe that somebody is after you when they're not. You may
That's
believe
delusions of persecution.
persecuted delusion, yes. Or, for example, where you may believe that you are a millionaire when you're not. You know,
Delusions of grandeur.
and so on. So those are examples of false beliefs that you actually may have that are unreal. And then another feature would be disorganized behavior, where you do things that are really not appropriate, you know, either in private or in public.
But having said that, you can admit these people for a few days, put them through treatment, give them medication, get Bonitas here to come up and do a proper interview and understand the psychosocial factors and see how best they can begin to change the way they think, and also getting to understand what informs their way of, and everything else.
Yes.
And typically, patients like that, within 3 to 4 weeks, they are discharged from hospital, they can go back home. But we do also know that these kind of patients can also end up at Vescopies or Sterkfontein, and they remain schizophrenic symptoms, as it were, for some of them for the rest of their lives.
Yes.
Now, what influences that? Why do some people get better and some people are almost, condemned to chronic care, as it were? They have to remain in hospital for the rest of their lives.
Maybe just talking specifically about schizophrenia, it's the different types of schizophrenia that tend to have different outcomes. You know, patients with the more disorganized schizophrenia, their prognosis is a bit worse and their level of functioning is a bit lower than those with paranoid schizophrenia. So a lot of patients that we find in these institutions for many years with residual symptoms, you find that in the beginning, in the very beginning when they were younger, it was more a disorganized picture that they presented with.
I see. Now, in your view, you have to deal with these people when the colleagues have done everything else, and you now have to deal with the way they think, and you have to deal with their behavior, and you have to deal with some of their other beliefs that they have, and so on and so forth. Now, do you find that in terms of relapse, from what you do, trying to assist them to reintegrate back into society, hopefully go back to work or go back to their families, what are some of those things, factors at play, that make them to relapse into their conditions?
Okay. Some of the factors that contribute would be poor understanding of the condition.
I see.
If a patient himself does not know what's going on with them and what the condition is doing to them, then they would find it difficult.
Does level of education have a role to play here? Because I mean, the gentleman that we had in the inset, very articulate, clearly very educated, can understand what is wrong with him. But I can imagine somebody who's less educated may not understand what is wrong.
Yes.
However hard you try to explain.
Yes, so level of education does have an impact. That's why it's important to use descriptive language when you speak to patients to describe what is happening than to use more of a labeling language that they cannot comprehend.
Okay.
So poor understanding would contribute. If they don't adhere to treatment, which is typical in in patients with schizophrenia, because remember their thinking is impaired. So it's very difficult for them to even.
So they need supervision. They need somebody to assist them in taking their treatment. Yeah.
So that would bring us now to social support. Who do they have in the environment who would help administer treatment and so forth? And remember, they may be difficult at times. So imagine with someone who has even persecutory delusions, when we say, sister, administer treatment, the biological sister, to your own brother, and they think, no, my sister wants to kill me. So it would be difficult even to get them to cooperate. One of the things that contribute to is if the stigma. When people feel I'm not going to do this, they think there's something wrong with me, or they're afraid of stigmatization, then they don't adhere.
Because
to
more often than not, I mean, you hear them complaining. So there's always a certain level of denial. Is it because of the stigma? Is it because of lack of understanding, or because I really have to come across people who say, look, people who will introduce themselves in a social setting and say, listen, I'm bipolar, I'm on treatment. People never really disclose themselves that way. You actually have a better chance of somebody saying they're HIV positive than that they have bipolar or some of these other conditions. But why do people deny that they have mental
It's because of
conditions?
the stigma, but sometimes because of the public not understanding. It's the way we treat them as well. You know, we treat them as if you are mad. And often when the family or society or people are tired of them, they tend to just leave them. Remember the gentleman spoke about people just saying, okay, have it your own way, and then he ended up in the streets. So sometimes people give up on them because they're tired, and it really is frustrating to take care of someone whose thinking is distorted.
It takes a toll on the family.
Yeah, it does. It does.
Now let's talk about, I don't know what it is called. They call them prisoners of the state or patients of the state. What kind of patients are these?
These are people who have committed a crime, and when they are then presented to the judge or the magistrate, they found perhaps that there's maybe due to the mental illness, that's why they committed,
a particular crime.
So they do not appreciate the wrongfulness of their acts, and they are not fit to stand trial, for example. That's when they will then be made state prisoners. So they are not then sent to correctional facilities.
Services.
They are then sent to chronic psychiatric facilities like Sterkfontein, like Weskoppies Hospital, where they will then be treated in a maximum security facility. Like in prison, they are maximum security because they are a potential danger to society.
But some of them, like the late Dimitris Afendas, who was alleged to have assassinated President or Prime Minister Verwoerd. I mean, up to his death, I mean, he was there for more than 30 years. I mean, he never really got better. Now, some of these guys, you can give them treatment, you can put them there, and they just never really get better.
Well, it's a mixed picture. It's a mixed picture because it has to do with the severity of the illness.
Yeah.
And I think you made reference during the intro that some mental illnesses are acute or brief, short-lived. So if you commit an offense when you have an illness for a few days or a few weeks, you could actually get better and even recover from that illness. And in that case, you can then actually be discharged from being a state patient and go back into the community, go back to work, go back to school, and so on.
And go back to trial even.
In some instances, yes, the law does provide that if you are not fit to stand trial, if you've recovered, the prosecutors can actually take you back to court. If it is believed that you may actually be responsible for your actions. And I think just to clarify, Dr. Ramathesele, that the two reasons why you could be a state patient that Dr. Dikobe referred to, one is that you are not accountable for your actions because of mental illness. But another reason is that you are not actually fit to stand trial. So you may have been accountable.
Subsequent, you may have been sober and everything when you committed the crime. But subsequent to that, you're just not in a proper mental state.
So maybe if you're committing armed robbery and then get injured in the process after the alleged offense, you may then have a head injury, which means that you're not fit to stand trial in a court of law.
I see.
But if you recover from that head injury, you may actually subsequently become fit to stand trial. You may still then be held accountable for the alleged armed robbery. That would be an example. So people can get better and be discharged and go, back into the community. But on the other hand, depending on the severity and the chronicity of the illness on the one hand, but also depending on the seriousness of the alleged offense, that can actually determine the extent or the length or duration of your hospitalization as a state patient.
Interesting. Mzikaba akakho umuntu ke onozikhethela kuba yena uzawuphatha sisifo sengqondo ke. Sithi Xhosa ke ziyabotshwa xa zibhijile ke. Kuyanyanzeleka ukuba umuntu ozifumana kule meko aqonde imeko yakhe nemibandela yesigulo sakhe. Kananjalo ke aqiniseke ukuba ufumana uxhaso losapho lakhe oluzenzela ukuba ke unyango lakhe lube nempumelelo le ayinqwenelayo. We'll continue our discussion on chronic mental disorders after the break. Welcome back. One is Rosazo Pelagashlo Salatimona Bonitas House Call or SABC 2. And today we are talking about chronic mental disorders. Now, quickly, Dr. Tembe, we know that South Africa, unfortunately, has one of the highest prevalence and incidence of HIV infection. And I would suspect that some of the burden that we have in this country, insofar as chronic mental disorders is concerned, is influenced in one way or another by the number of HIV people, positive people we have in this country. What is the relationship between the two conditions?
There is actually a strong relationship between HIV and mental illness. And I think one of the reasons for this is that the human immunodeficiency virus mainly targets two organs in the body. First one, the immune system. The second one is the central nervous system, the brain, spinal cord, nervous tissue. So for that reason, we find that in HIV illness, there's actually a high incidence of mental disorders associated with HIV.
I see.
The commonest one...
Where you have a physical condition leading to a mental disorder.
Absolutely. Absolutely. So in people living with HIV and AIDS, we find that there is a higher incidence of depression compared to those who are HIV negative. So depression is a big one. Another big one is...
And it will be depression over a long time.
It will often be over a long time, although it can be modified. It can be modified by treatment, including ARV treatment, psychosocial treatments, and even psychiatric treatments. So all of those will modify the course of depression in HIV. Another common psychiatric disorder in HIV is dementia, or perhaps more specific, we say cognitive disorders. Because when we say cognitive disorder, there will be varying degrees of severity. It can be mild, it can be moderate, it can be severe.
Do you want to define dementia?
So dementia is another psychiatric disorder which is characterized by impairment in a number of what we call cognitive functions. Now, cognitive functions is like your ability to learn, your memory functions.
Intellectual functions.
Intellectual functions.
I see.
Intellectual functions. Memory, intellectual level, the level to which, the ability to which you're able to learn, what is called executive functions, that is the ability to plan and judgment.
Now, how do
of the
HIV
treaty
people
functions.
get affected by this? Is it because of the virus itself that affects certain parts of the brain, or are there any other factors that may?
It's mainly because this virus has as one of its key targets the brain.
Yeah.
So the virus
I see.
directly
So those
attacks the brain.
faculties get affected. Yeah.
Yes, but also we should also remember that in advanced HIV disease, there will be what we call opportunistic infections, some of which can also affect the brain.
Okay. Now you deal a lot, especially in Pretoria, Nyaupe, Baji, and many other. In Durban, it's Wunga, and it's got ticks and cocaine. Now, how do these substances, and I'm sure you come across a lot of them quite often, how do these relate and lead to chronic mental disorders?
Substances can be taken to deal or cope with the mental disorder.
I see. People already have a mental disorder using substances as self-medication. Yeah.
So that is
But some of the substances can cause mental
some-
disorders themselves.
Yes,
I
and then
see.
sometimes when they're taken, whether they started off experimentally, they can cause mental illness themselves.
I see.
So there can be an interplay there. Yeah.
Now, does marijuana on its own, continuous use of marijuana, lead to some form of psychosis, as some people believe? Is that fact?
I believe if it's a lot, it can lead to that.
I see. Now, trauma is a big problem in South Africa. If you talk about the quadruple burden of disease in this country, the fourth party talks about mental disease and, among other things, trauma, whether it is homicidal or whatever. But in the final analysis, how does trauma in itself influence the number of people in this country who have chronic mental disorders?
We have a lot of trauma in our country with the motor vehicle
Psychological and
accidents.
physical.
Yes, with the motor vehicle accidents and assaults. A patient who suffers a blow to the head can then suffer from what we call traumatic brain injury.
I see.
And that traumatic brain injury can manifest in a number of psychiatric conditions. They can present with neurocognitive impairment due to the traumatic brain injury. Some of them can present with psychosis due to the traumatic brain injury.
Would it be a safe conclusion to draw that if a person has had a psychiatric condition, whether it is short-term or one that has been kept under remission for one reason or another, that happens because there are predisposing factors. And the predisposing factors were met with psychosocial stressors, a death in the family, a break-up, a loss of a job, or whatever, and then that triggers the psychiatric condition that we see. That patient remains vulnerable, even if they would have recovered. Or they are in a remission of sorts, they remain vulnerable. And because they remain vulnerable, there are certain things that they must continue to do, or there are certain things that they must avoid in order for them not to go back to that situation. And what are some of those things?
Yes. So now we're talking about mental health promotion.
Yeah.
So we shouldn't just treat mental illness when it occurs, but we should actually, as a society, we need to work hard at promoting good mental health. Some of those aspects will be things like just learning to take care of yourself, learning to have a healthy, balanced lifestyle where you have adequate rest, you have good nutrition, you exercise.
Tell that to the executives.
Exercise.
So those are some of the things that you must do, but also not to make yourself available to outguess some psychological stress or abuse in one form or another, if you can. That is.
Absolutely. Good principles of stress management. Dealing with stress as an individual and within your context, whether it's family context, work environment, school environment, learning to deal.
Easier said than done. Asiyeke lapho nje bandla kwethu asiqinisekise ukuthi umuntu akalahlwa ke umuntu. Kuyadabukisa ke ukubona abantu abagula ngokwengqondo ke umuntu esengusikhotheni elala emaweni, abanye ke behla benyuka nama-freeway noma imigwaqo kathela kwayeka. Impilo zabo sesize saba sengciphekweni ngenxa yalesimo abakusona. Kanti akhona amakhaya abaqhamuka kuwo okufanele abaxhase ngaso sonke isikhathi. We'll run up our discussion on chronic mental disorders when we return. You're watching Bonitas House Call here on SABC2 and welcome back. Bagaiso mo gongwile borwa. Me re konosetsa thulaganya rona ka mafoko a tshedimosetso go tswa go ba itsanape ba re bong re balaleditse. Ma'am, your parting message.
I always advocate that people should consult and seek help, but where do they go? So people from home, if you do not have enough funds to consult, go to your nearest clinic, and the doctors at the clinic will refer you to the district hospital and then up to the level of academic hospitals and so forth. If you've got medical aid, you can start with your GP or you can go straight to any hospital, and then they would be able to locate the specialists in.
Don't be too strong. You feel there's a problem, you must go and consult a professional.
Go and consult a professional.
Dr. Tebe?
I was actually encouraged by the story of the patient that you interviewed to see that as much as he has this severe mental illness, at some point living on the streets, but hey, he's recovered a very good level of functioning. He's undergoing rehabilitation. So certainly the message to our viewers today
And he's
is
gainfully employed, as I could say.
gainfully employed. The message to our viewers today is that there is hope against conditions of chronic mental disorders.
I saved the best for last, Dr. Dikobe.
I always tell my patients about chronic mental illness that it is like diabetes, it is like hypertension. Somebody who is diabetic has a good quality of life because they take their medication lifelong.
I see.
You are hypertensive, you will be normotensive for as long as you take your medication. So with mental illness, if you have been diagnosed with a chronic mental illness, you take your medication lifelong. And I joke with them and I say, even beyond this life, you are sitting on the dinner table with your creator, you take your
You must
medication.
continue your medication. And family members, society, we need to embrace these people. Some of them might be a little bit dangerous sometimes, and we have the law to take care of that, but we need to embrace people with mental illness and assist them to maintain their remission or to be as well for as long as they can. Bitumelo, Dr. Tebe, Dr. Lerato, thank you ever so much one more time. I think you've really helped us in understanding and how exactly to deal with some of our loved ones who might be affected by these conditions. Banabeso, nnete ke a moroho, let's try ke back. Re science he rona le tsatsing la kajeno. Le ho nna bohle he barati ba tshetsi ba thaselli ba khothumetse e ka sitsana le ba manokeng ba lenano le. Re tanki hangwe, tanki habedi, tanki hararo. Re ha re mene le tlhabela re ela di khala. We'll be back next Saturday with Parkinson's disease. So don't miss it here on SABC2 at 8:30 in the morning. Tato Hailiamren. Thanks for joining us today. For me, Dr. Victor Ramathesele, ke motjhane mochicha, ke motjhane wa Maswati, ke moramakuapa na manesehla motangwa mletsana. You take care.